Neurology. Under neurology, the first most important question that we should be reading is acute bacterial or pyogenic meningitis. So, and also tubercular meningitis. It has been many times asked as 10 marker and 5 marker. I am not going through these topics because we have studied extensively about these topics on our microbiology days. So, I will be starting with epilepsy first. The other important 10 markers are Parkinsonism, the epilepsy we'll see, and then myasthenia gravis. And also important 5 mark questions are trigeminal neuralgia, Parkinson's disease, which has been asked many times, also migraine headache and trigeminal neuralgia. Myasthenia gravis is an important 5 marker question also. So we'll be seeing through this topic briefly. First, I am starting with epilepsy. What is epilepsy and seizure? Seizure is signs and symptoms seen, transient signs and symptoms seen due to excessive hypersynchronous activity or stimulation of neurons. The transient signs and symptoms seen due to excessive hypersynchronous activity of neurons is called as seizure. Now, what is epilepsy? Epilepsy is more than or equal to 2 unprovoked seizure with no identifiable causes like hypoglycemia, hyponatremia. All these reversible causes should not be there. So more than equal to 2 unprovoked seizure which are separated by 24 hours, or if there is one episodes of seizure with the evidence of epileptiform syndrome, or on MRI or ECG we see the occurrence of next seizure is more than 60%. Like the lesions like brain tumors and all can cause recurrent seizure. So all those will be called as epilepsy. The types of seizure or epilepsy, we have generalized seizure and focal onset seizure. What is the difference between generalized seizure and focal onset seizure? Under the generalized seizure is the seizure where the activity of neurons, that is hypersynchronous activity, can't be localized to the specific site, meaning during the onset of seizure the diffuse activation of both the cerebral hemisphere will be there. That is called as generalized seizure. In focal onset seizure, there is a specific region in the brain where this hypersynchronous activity is arising. It can be localized and then gradually it may spread to involve both the cerebral hemisphere and it may cause generalized epilepsy, but the origin is focal. It can be localized to a particular site. Most commonly, the focal epilepsy are due to structural abnormalities like tuberculosis, neurocysticercosis, or any tumors causing it. We will discuss the in deep. And generalized variety is maybe due to structural abnormality, cellular abnormality, or biochemical abnormalities. So under generalized seizure, we have generalized tonic-clonic seizure, myoclonic epilepsy, and absence seizure, and atonic and clonic, tonic, and other types of seizures are there. We are discussing GTCS, myoclonic epilepsy, and absent epilepsy, and atonic epilepsy. First, let us discuss the focal one, where the focal one are divided into simple partial seizure and complex partial seizure. The simple and complex partial seizure are divided based on the disorientation of the patient. If the patient consciousness is impaired, if the cognition of the patient and consciousness is impaired, meaning the patient is not oriented to the environment, then it's called as complex partial seizure or seizure with disorientation, focal epilepsy with discognition. Or also we can have simple partial seizure where the consciousness of the patient will be intact, it will not be disoriented. That is called a simple partial seizure or seizure without discognition. So let's see simple partial seizure. The simple partial seizure is most commonly we see motor manifestation is there in case of simple partial seizure. What is the etiology of simple partial seizure? Simple partial seizure can be due to structural lesions in the frontal lobe or frontoparietal lobe, which causes motor activity, motor manifestations, most common one. Or there can be microbial infections like tuberculoma or neurocysticercosis causing simple partial seizure. Post-stroke or tumors of brain can cause simple partial seizure. What are the clinical manifestations of simple partial seizure? Simple partial seizure usually manifests with clonic movements. Clonic movements is the rapid contraction and relaxation of the muscles, or tonic-clonic movements, where there will be tonic contraction followed by clonic, that is contraction and relaxation. Tonic is only sustained contraction, followed by sensory or autonomic abnormalities like sensory abnormality like paresthesia, numbness in particular part of body, or autonomic features like flushing, paleness, and palpitation, etc., can be noted in simple partial seizure. We saw in simple partial seizure, it involves a specific area of the body. Most commonly, it shows motor manifestations. That is clonic, more common than tonic-clonic manifestation. This motor manifestation usually starts at a site, and then it gradually spreads over the other corresponding motor area to cause involvement of other parts of the body. The progression of motor manifestations in simple partial epilepsy, simple partial seizure has been described as Jacksonian march, where the motor manifestation starts at a point, at an area, and gradually spreads to involve the other surrounding motor cortex and causes corresponding manifestations in the body. One of the example for Jacksonian march is march of manifestations from face to involving ipsilateral upper limb, ipsilateral lower limb, contralateral lower limb, and then contralateral upper limb and contralateral upper limb. Like this, it may progress. This is called as Jacksonian march. Or other example, we have here the march of the clonic or tonic-clonic manifestations from the distal muscles to the proximal muscles. So these are the examples of Jacksonian march. Basically, Jacksonian march is the motor activity is spreading in a particular way due to the involvement of corresponding the surrounding motor area. This is called as Jacksonian march. So under clinical manifestation of simple partial seizure, we have one variety. This is called as epilepsia partialis continua, meaning the epilepsy continues for hours to days and it is refractory to drug therapy. We have Todd palsy in case of simple partial seizure, where the patients will experience transient paralysis of the muscles for minutes to hours following the attack of simple partial seizure. This is called as Todd's palsy. We can perform MRI based on the lesions. We'll see specific manifestation for it. The management part we'll discuss shortly. And the management part, most important in simple partial seizure is management of the cause. We know the secondary causes like structural lesions, microbial infections, post-stroke, or tumors are responsible for simple partial seizure. First, you control the episode of seizure, then treat the underlying cause of the. So thereby you will be treating simple partial seizure. Next, we are going on to complex partial seizure. Complex partial seizure, in contrast to simple partial seizure, doesn't show motor manifestation more commonly. It usually shows sensory and autonomic manifestations. And also, the complex partial seizure, in contrast to simple partial seizure, is have family history. It runs in family. It's not usually due to structural lesions. One of the most important syndrome, epilepsy form syndrome causing complex partial seizure is medial temporal lobe epileptic syndrome. In that, the etiopathy we have temporomesial fibrosis and hippocampal sclerosis in the medial temporal lobe, and there will be positive family history. The clinical manifestation of complex partial seizure is, first, there will be aura. There can be aura is what the patient feels before the onset of the seizure attack, the ictal stage. The patient may have the abdominal bloating or abdominal fullness effect, that is called as abdominal aura, more common than visual hallucinations and the auditory hallucinations or auditory aura. Then followed by that, the patient will have his face where he'll just stare on something, and there will be loss of consciousness during that time, meaning the consciousness will be impaired during that stage. Following that stare stage, the patient will have automatism, like chewing, lip smacking, like this automatism will be there. This is the ictal phase, that is during the attack of complex partial seizure. Following that, the patient will have post-ictal stage, where the patient have anterograde amnesia. You won't remember anything about the complex partial seizure attack and few minutes around it. The investigations of complex partial seizure is MRI. Yeah, on MRI, we can see hippocampal sclerosis. On EEG, we will see temporal spikes. The drug of choice for complex partial seizure treatment is carbamazepine. Now, we are done with focal onset seizure, that is focal or partial seizures. Next, we are going to generalized seizures, where we have diffuse activation of both cerebral hemispheres. We saw the types are generalized tonic-clonic, myoclonic, and absence and atonic seizures. First, we are going through etiology of generalized tonic-clonic seizures. What is the etiopathophysiciology of this condition, generalized tonic-clonic seizure? These seizures may be secondary to other diseases like sepsis, secondary bacterial sepsis, and spread of infection to CNS. We can have GTCS, and also secondary to metabolic abnormalities like hyponatremia, hypomagnesemia, and rarely hypermagnesemia and hyponatremia may cause GTCS. Hypocalcemia may cause GTCS, and also most importantly, hypoglycemia may cause GTCS. The intake of some drugs like lithium, tricyclic antidepressants, fluoroquinolones, imipenem, and theophylline has been associated with GTCS, and withdrawal of drugs like CNS depressants like barbiturates, benzodiazepines, and withdrawal of alcohol has been associated with generalized tonic-clonic seizure. The primary diseases involving brain which causes GTCS are encephalopathy. It may be hepatic encephalopathy or uremic encephalopathy, or post-stroke the patient may have GTCS, or encephalitis due to HSV infection, Japanese encephalitis virus causing encephalitis, or autoimmune encephalitis can cause GTCS. These are the primary and secondary causes of GTCS. Now, how does the patient clinically presents? How does the patients have manifestations during the attack of GTCS? First of all, these patients will not have any warning symptoms before the onset of GTCS, unlike complex partial seizure, where the patient will have aura. During first initial 10 to 20 seconds, the patient will have tonic contractions of all the muscles. So due to this, the patient may have loud moan, ictal cry, or tongue biting during tonic phase. And also during tonic phase, there is increased sympathetic activity causing increase in heart rate, BP, and cardiac output. Following this 10 to 20 seconds of tonic phase, the patients will have clonic phase, where there will be rapid contraction and relaxations of the muscles, which we see. After this attack, the clonic stage, the patient will have post-ictal stage, where the patient will have amnesia, muscular flaccidity, loss of consciousness, and increased salivation during post-ictal stage. Next, we have myoclonic epilepsy. Myoclonic epilepsy is rapid contraction and relaxation of particular group of muscles of the body. It can be due to anoxic brain injury, degenerative diseases of brain like Alzheimer's, Huntington's, chorea, etc. Metabolic diseases of brain can also cause myoclonic epilepsy. And the most common epileptic syndrome associated with myoclonic epilepsy is juvenile myoclonic epilepsy, where we usually see juvenile myoclonic epilepsy in the female patients at the age of 6 to 25 years. It is associated, the exacerbation of juvenile myoclonic epilepsy is seen on sleep deprivation. 90% of patients with juvenile myoclonic epilepsy has GTCS, and 1/3 of them has absent seizure. The clinical manifestations are brief loss of consciousness associated with contraction of muscles like upper limb muscles more than lower limb muscles, face and trunk muscles, or generalized contraction of muscles. On EEG, we see polyspike and wave pattern. This is about myoclonic epilepsy. Then going on to absence seizure. We have typical childhood onset seizure and atypical juvenile absent seizure. Typical childhood onset seizure has onset between 4 to 10 years, where the child will have the clinical manifestation where there are no motor manifestations in absent seizure. There will only brief loss of consciousness. The patient may stare for some time, and then it may be followed by automatism like chewing, lip smacking, and also increased eye movements. This typical childhood absence seizure is exacerbated by hyperventilation like blowing rocket or crying. The blowing rocket part can be used clinically to test for typical childhood onset seizure. The EG findings are 3 Hz spike and wave pattern, 3 Hz spike and wave pattern, 3 Hz spike and wave pattern. Here you can see the spike is rapid upstroke and outstroke. This is the sharp. Spike and wave pattern is spike followed by wave, spike followed by wave. In 1 minute, we have 3 spike followed by wave. It is called as 3 Hz spike and wave pattern, which is in typical childhood onset absence seizure. The atypical one or juvenile absence seizure is usually seen between 9 to 13 years of age. The clinical manifestations are in atypical one, the time duration of loss of consciousness is increased compared to that of typical childhood onset seizure. And also during typical childhood onset seizure, typical absent seizure, there is no loss of postural control. But in case of atypical one, we have loss of postural control. The drug of choice is valproate for atypical juvenile absent seizure. The typical childhood absent seizure, we can use the drug only till 12 years of age, and then we can stop it. This is the only condition where we stop at 12 years of age. All other conditions, mostly, except for simple partial seizure, we give drugs for lifelong. So we are done with GTCS, myoclonic epilepsy, and absent seizure. Let's see briefly about atonic epilepsy or seizure. Here we may have, in the atonic seizure, we have loss of tone of muscles of the body, which may lead on to drop attacks, etc. We have one syndrome called as Lennox-Gastaut syndrome associated with atonic seizure, where the patient will have mental retardation associated with atonic seizure. And also these patients of Lennox-Gastaut syndrome have tonic seizure, atonic seizure, drop attacks, or absent seizure. The EG findings in atonic seizure are slow spike and wave pattern, which are seen in Lennox-Gastaut syndrome. So this is about the focal onset and generalized onset seizure. Next, we see the management of this condition. What are the investigations that we will do in case of seizure? We can do blood investigations like serum glucose level, because hypoglycemia can cause it, and serum calcium levels and electrolyte levels, because these are the one of the causes of GTCS and other forms of epilepsy and other forms of seizure. And we can do lumbar puncture if we suspect CNS infections and autoimmune encephalitis. If we do ECG, we can classify the type of epilepsy the patient is having based on the pattern of EEG, some of which we discussed while discussing the specific topics. And in 40% of patients, the EEG findings can be normal. This point is very important. And we can do MRI or CT if the patient has any brain lesions like brain tumors causing simple partial seizures, etc., etc. And also there will be hippocampal sclerosis in case of medial temporal lobe epilepsy syndrome. This is about the investigations. Under treatment, we have treatment of generalized and partial seizures. The generalized seizures, the GTCS we treat with valproate. The juvenile onset myoclonic epilepsy we treat with valproate. The absent seizure also we can treat with valproate, but in case of typical onset absent seizure, less than 3 years, we prefer etosuximide. Alternative to valproate, we can use lamotrigine and topiramate. The adverse effects of valproate are weight gain, pancreatitis, alopecia, hepatotoxicity, and increased ammonia levels. Partial or focal onset seizure, the simple partial one, I told you we should identify the condition, structural lesion causing it, and treat it accordingly. If it is complex partial seizure, it's familial syndrome, not associated with structural lesions, where we give carbamazepine. One of the side effects of carbamazepine is SIAD, syndrome of inappropriate ADA secretion. Then we can give lamotrigine or levetiracetam to these patients. Levetiracetam is the safest drug which can be used in pregnancy. Even in generalized onset seizure also, we can use levetiracetam in pregnant females. Now let's see the epileptiform syndromes which are commonly seen associated with epilepsy. Those are juvenile myoclonic epilepsy, which I already discussed. Lennox-Gastaut syndrome, characterized by triad of multiple types of seizures like atonic, tonic, GTCS, and also my atonic seizures. Also, the patient will have cognitive impairment and slow spike and wave pattern on EEG. The cause of Lennox-Gastaut syndrome is CNS infection, trauma to the head, and also perinatal hypoxia are some of the few causes of Lennox-Gastaut syndrome. We have other epileptiform syndrome called medial temporal lobe epileptiform syndrome, which is where we see complex partial seizure, and also we see hippocampal sclerosis and treated with carbamazepine. The febrile seizure is one of the epileptiform syndrome, which is seen between 3 months to 5 years of age. It can be simple or complex type. Simple are single isolated brief events. Complex type are usually they show focal seizures. The duration of seizure is more than 15 minutes, and also they have recurrent seizures. The complex febrile seizure has increased risk to develop epilepsy in the adult. So next, the last topic we are discussing, status epilepticus. Now, what is status epilepticus? If the episode of seizures continues for more than 5 minutes, or there are more than or equal to 2 discrete seizure episodes without regain of consciousness in between the 2 discrete episodes of seizure, it is called as status epilepticus. Now, what are the causes of status epilepticus? Alcohol withdrawal, HSV infection, withdrawal, HSV infection. Post-stroke, the patient may have or metabolic abnormalities like hypoglycemia, hypocalcemia, and other electrolyte imbalance can cause status epilepticus. The types of status epilepticus are convulsive type, non-convulsive type, and refractory type. In convulsive type, the patient will show motor manifestation, that is convulsions. Non-convulsive type, the patient will not show motor manifestations. You will only have the EEG findings in case of non-convulsive type. The refractory type are those who are refractory to drug therapy. We have 2 phases of status epilepticus. Those are compensatory phase and decompensatory phase. In compensatory phase, there will be increased sympathetic drive inside the body, which leads to increased cardiac output and BP in the patient, followed by decompensatory phase, where the patient will have reduced cardiac output, reduced oxygen supplies to the systemic tissues, reduced systemic perfusion, where we may have, due to this, we may have cardiac arrest, and also we have in decompensatory phase, we may have rhabdomyolysis and hyperthermia. Rhabdomyolysis can secondarily cause tubular toxicity and ATN, and also we may have increased intracranial pressure during decompensatory phase, which may lead on to cerebral edema and rarely herniation in these patients. And also we have, what are the monitoring that we do in case of status epilepticus? We will do continuous EEG monitoring if the patient are comatose for 48 hours, because we may have non-convulsive status epilepticus in these patients, which we will miss. So we'll do continuous EEG monitoring if the patient is comatose for 28 hours. We'll do it. Now, what is the treatment for status epilepticus? Status epilepticus is treated in first 5 minutes. We'll first assess the airway, breathing, and circulation of the patient, followed by rapid IV access, and then we'll do EEG monitoring of the patient. We'll draw the blood for serum electrolyte estimation and serum glucose estimation. Following that, we start the patient on treatment. If the patient has IV access available, we'll start with IV lorazepam 0.1 mg per kg, 0.1 mg per kg. Or if the patient doesn't have IV access, we'll give midazolam IM or intranasal midazolam 0.5 mg per kg. If the seizure doesn't stop in 5 minutes, we'll repeat the lorazepam, IV lorazepam 0.1 mg per kg, slow push, oral. On giving this also, if the patient doesn't recover, we'll start with second line drugs like phenytoin, fosphenytoin, valproate. The valproate 30 to 40 mg per kg, phenytoin at 20 mg per kg, and fosphenytoin 20 mg per kg. If the patient doesn't respond to this also, we'll give third line drugs which are anesthetic drugs like propofol, phenobarbital, and thiopentone sodium. This is about status epilepticus and seizures and epilepsy. Seizure is transient signs and symptoms seen due to hypersynchronous activity of neurons. Epilepsy is more than or equal to two unprovoked seizures, which are separated by 24 hours or once episodes with evidence of epileptiform syndrome. The types we have focal type and generalized type. Under focal, we have simple partial seizure and complex partial seizure. Simple partial seizure is usually due to secondary structural abnormality, and most commonly it shows motor manifestation. The complex one is most commonly doesn't show motor manifestation, it shows sensory and autonomic manifestations. The most common syndrome is medial temporal lobe epilepsy. We treat these patients with carbamazepine. The generalized seizures we have GTCS, myoclonic epilepsy, absent seizures, and atonic. GTCS is caused due to secondary to metabolic or sepsis, abnormalities of encephalitis post-stroke or encephalopathy, uremic or hepatic encephalopathy. Clinical manifestation, first we'll have tonic contraction of muscles followed by clonic movements, and then post-ictal where we see muscular flacidity and increased salivation. Myoclonic epilepsy can be due to anoxic brain injury, juvenile myoclonic epilepsy, degenerative diseases of brain. And the absent seizure, we have typical childhood seizure and atypical one. Atypical, we give drug therapy till 12 years of age. Atonic one, we have Lennox-Gastaut syndrome, one of the association causing atonic seizure, where on EEG we see slow spike and wave pattern. Investigation, we perform blood investigation, lumbar puncture, EEG, and MRI. The treatment we give most commonly valproate in all the conditions. It's the drug of choice. Alternative, we can give lamotrigine and topiramate. During pregnancy, we can give levetiracetam or lamotrigine. The carbamazepine is the drug of choice in complex partial seizure. Some epileptiform syndrome are juvenile myoclonic epilepsy, Lennox-Gastaut syndrome, medial temporal lobe epilepsy syndrome, and febrile seizures. Then we saw status epilepticus, where the patient have the seizure activity lasting for more than 5 minutes, and also if the patient has more than or equal to two discrete seizure activity with no regain of consciousness between those seizure episodes, it's called as status epilepticus. Some of the causes are alcohol withdrawal, HSV infection, metabolic, and stroke, post-stroke. The types are convulsive, non-convulsive, and refractory type. We have two phases, that is compensatory and decompensatory. Compensatory, there will be increased sympathetic activity. Decompensatory, the patient will have cardiac arrest, rhabdomyolysis, increased ICP. Monitoring, will do continuous EEG monitoring for 48 hours in comatose patient to look for non-convulsive status epilepticus. The treatment, we have first 5 minutes, we'll look for will manage airway breathing circulation, followed by IV access, EEG monitoring, and we draw the blood for investigation, serum electrolytes and serum glucose. First, we'll give lorazepam 0.1 mg per kg or midazolam intranasal 0.5 mg per kg. Then, if the patient doesn't respond in 5 minutes, we'll give IV lorazepam 0.1 mg per kg. If it doesn't respond, again we'll start with valproate 30 to 40 mg per kg, and then the third line is propofol, phenobarbital, and thiopentone. Thank you for listening.